Okay, we're going to start talking about chronic kidney disease now. We spent some time with acute kidney injury, where our primary goal is to treat the underlying cause and then support our cues and our symptoms. Chronic kidney disease, this is a chronic process. Basically, it starts with damage. There are 5 stages that go through it, and the important thing about this is it uses the glomerular filtration rate to stage the patient. So these are defined definitions of these stages, and they're based on how that glomerulus is functioning. So again, you don't need to memorize these stages. It's good to know that glomerular filtration rate is 90 or above. And once you get below 90, so if you're going to remember anything off of this slide, is really the important number to remember is the glomerular filtration rate of 90. Let me see. I was going to draw, but it won't let me draw. So remember 90, anything less than 90 is going to be considered renal failure, some stage of kidney disease and starting to go into renal failure. So our interventions are going to be stage-based. Stage 1 and 2, you don't have much damage or you have mild damage. Our goals are going to be reversing underlying processes. And once you get into stage 3, 4, and 5, we're managing symptoms and dealing with the fact that we're probably losing a good majority of our kidney. Now remember, we're not going to see these numbers, these renal function numbers, go down until we are gotten down to about a half or a quarter of a remaining kidney. So this has been going on for a long time, killing off a lot of nephrons before we even see the glomerular filtration rate decrease. So a lot of times kidney disease has been happening for decades, non-staged, pre-staged before we even start to see renal function decrease. Once we hit that glomerular filtration rate less than 90, we're down to a very small remaining amount of one kidney. And then from there, it progresses through the stages until you have no kidney function left. So stage 1 and 2, there are no cues. All right, no outward signs or symptoms that you have this damage to your kidney, and you just have risk factors. So the important thing in stage 1 and 2, very similar to the risk stage of acute kidney injury, this would be the risk stage of chronic renal failure. And the risk factors are having long-standing diabetes, hypertension, dyslipidemia, coronary artery disease, heart failure, peripheral artery or vascular disease. Of course, the more risk factors you have, the much higher risk you have of progressing through the stages. So really, stage 1 and 2, just recognize your risk factors and mitigate risk factors. Very similar to any hypertension risk factors, diabetes risk factors. Managing your disease can prevent you from progressing to stage 3. So when someone has stage 1 or 2 chronic kidney disease, their job is to manage their diagnoses, their chronic diagnoses, and to prevent any further damage to the kidney in stage 1 and 2. So someone in stage 1 and 2 will not have oliguria, will not have any signs or symptoms, and is involved in monitoring and teaching. And teaching is risk management. So preventing the progression of your disease to stage 3 or higher. Blood pressure management, very important. Self-monitor their blood pressure, compliance with blood pressure medications, blood sugar control if they are diabetic, and then monitoring for any signs and symptoms. If you're in stage 2 chronic kidney disease, how do you know if you've progressed to stage 3? It's usually symptoms start to show up, like fluid retention or maybe an increased BUN creatinine glomerular filtration rate on their annual labs. So basically keeping healthy, eating healthy, exercising, stress management, blood pressure, blood sugar control management. Stage 1 and 2, managing underlying disease processes and preventing progression. This is just a reminder of all of your hypertension meds. Again, there are 4 main categories of hypertensive meds. We don't prescribe them, but we do encourage patients to continue their doses, reporting side effects that they don't enjoy, because it is so important to stay compliant with your hypertensive meds and making sure your blood pressure stays under control to prevent progression of your chronic kidney disease. So again, just re-familiarize yourself with the classes of hypertension meds. These will come back at you again and again and again. They're going to come back at you at heart failure. They're going to come back at you on NCLEX. They're going to be patients. It's one of our most common diseases in the U.S. Most of our patients that we see are going to be on some form of hypertension meds. So please, please, please know the classes of meds. The ones that will help any kidney damage or will mitigate the factors of kidney damage. Remember, kidneys do help control our blood pressure, and they use that using the renin, angiotensin, aldosterone system. So if our kidneys are damaged to the point that they're releasing renin inappropriately, then the ACE inhibitors and the ARBs will help prevent any extra hypertension from kidney damage. But before the kidney damage, when you're in stage 1 and 2 and you have mild kidney damage, it really doesn't matter what blood pressure meds you are on, as long as the physician has prescribed them and they are staying compliant with their medications. So I just put those there to refresh your memory on hypertension meds. Blood glucose control, again, this is a refresh your memory. They do want to keep your hemoglobin A1C level less than 7. Less than 6.5 would be great, but less than 7 is our goal. And just a refresher, if you do not know these metformin, the sulfas, the oral treatments, or for diabetic treatment, basal bolus dosing, please go back and refresh that. That is important education for blood glucose control. The renal diet, we introduce it. We talked about it in acute kidney injury, that it reduces, the goal of the renal diet isn't to reduce heart damage or kidney disease. It's not, you see there's nothing about fat in it at all. It is to reduce the amount of acidic waste in the blood, because kidneys have to process acidic waste, and if they are starting to fail, then they probably are going to be a little bit less effective at processing waste. It's not important to enforce this diet at this stage 1 and 2. It's important to introduce them to it, as if you look at this diet, it's not very easy. And especially if they're already failing at following a diabetic diet, it will be very hard to follow the renal diet. It's a low sodium, adequate protein, adequate calories, and limiting phosphorus and potassium. So the low sodium part of this diet is less than 1,500 milligrams a day. I challenge yourself to go home and try to eat less than 1,500 milligrams a day. You will probably not get very far into your day before you're at 1,500 milligrams. This is a very restrictive sodium diet. And as they get into further stages, this becomes very, very, very important to follow and to enforce this renal diet. So, I mean, put yourself on a renal diet for the week until your test. And you probably won't enjoy it very much. And if you are able to do it, I would use this as a piece of education to any patient in stage 1 or 2 of renal failure, as do this diet for a week. If you hate this diet, please get your diseases under control, because in urine stage 3, 4, and 5, this is your diet, and this does become enforceable. So it's a good teaching point to show them the renal diet and say, if things don't get under control and you move into stages 3, 4, and 5, you will need to enforce this diet because your kidneys are too damaged to handle these objects. They can't handle extra calories, because extra calories are then converted to extra energy sources and create more waste. Protein gets broken down into the urea and nitrogen, so extra proteins, anything more than what you need, is going to cause extra waste products. Sodium is going to cause fluid retention, and when your kidneys can't get rid of fluid anyway, you will be retaining fluid if you eat any sodium. And phosphorus and potassium are in most foods, and when you have to limit them, because your kidney can't get rid of them if you eat extra, then you're going to be severely reducing your diet. I would use this as an incentive to stay in stage 1 or 2 or start reversing at this point, because this diet does become enforceable at stage 3. And so here again, foods to avoid, of course, sodium. We kind of all know the high sodium foods off the top of our bat. Phosphorus foods, though, this is really, high phosphorus foods really only come into play in renal disease, because they start losing their vitamin D ability to convert as the kidney gets more damaged. Then we have hypocalcemia, which makes hyperphosphatemia. We can't do anything about that. That's part of kidney disease. They will be hypocalcemic and hyperphosphatemic, so we avoid phosphorus foods. Foods that sometimes people think are healthy, especially if you're on a vegan diet and you're doing a lot of lentils or soys, those are actually very high phosphorus and will require somebody to double check themselves if they're headed into renal failure. Whole grain products, stuff that we consider not unhealthy, liver, some people don't think that's an unhealthy disease or an unhealthy meat, but the problem is when you have kidney disease, you do need to avoid anything with high phosphorus. So we're not talking just healthy diet, we're talking about really looking at your foods and eliminating foods that create waste for the kidneys. High potassium food, again, most of these are healthy choices. We normally don't mind having potassium. Most Americans are a little bit potassium depleted. Again, as a renal patient, though, your kidneys can't get rid of extra potassium. So if you have your spinach beet salad with tomatoes and squash, a nice summer salad from Perfect Pear, you're going to be super high in potassium and your kidneys can't get rid of it. So things that we think of, it's not so much a healthy diet, it's really knowing your foods and what to avoid. And unfortunately, we knock out a lot of healthy choices in the renal diet, and that makes it very hard to follow. High protein foods, of course, everybody knows protein foods that you eat in moderation, 0.8 per kilo. So really, an 80 kilo person's about 70 grams of protein a day, which some people it's hard to do, but in this land of protein bars, protein shakes, it's easy to get that high protein in 1 or 2 meals. They really have to pay attention to these things. So in stage 1 and 2, it's not that important. Your kidneys are still functioning, but it is important to introduce them to the renal diet so that they know what's coming if the hypertension, the diabetes, the hyperlipidemia doesn't get under control and your kidneys progress through to stage 3 to 5. So let's talk about what we're going to see as you end up in stage 3 to 5 kidney failure. Of course, kidney function is getting worse and worse as you progress through these stages. So your symptoms are going to get worse and worse as you progress through these stages. Here's what we expect to see. They are not great things to have, but they're expected. And the reason they're expected is because we have jobs of the kidney that are breaking down. Increased BUN and creatinine is job 1, eliminate waste. I don't think I'm spelling right, but eliminate waste. So if job 1, eliminate waste, is broken, then we will start having circulating waste in our system, okay? So as job 1 starts getting broken down and things aren't working well, we're going to have an increased BUN and creatinine. The other sign and symptom of job 1 not working out is itching. Waste products are itchy. They are toxic to our kidneys. So we start seeing these things because we can't eliminate waste. We end up in a toxic environment, and that toxic environment starts damaging nerves, starts causing itching, dry skin. So we expect this to happen. We're not doing a good job with job 1. The kidney's starting to fall apart. So wastes start hanging out in our bloodstream where they're not expected and where they start causing other problems. Job 2, in terms of blood pressure control, I think that's already part of our big problem there. We will probably see, let's add that to our list here. Knowing our jobs is great. Here, let's clear this off and let's write our jobs here. And we're going to redo this list so that it makes more sense with our job list. Our kidney jobs are, number 1, waste removal. Number 2 is going to be blood pressure management. Sorry, I'm scribbling. Number 3 was, let's say, fluid. I might be out of order from my other slides. Fluid management. Number 4, I'll come across it. Number 4 would be calcium and vitamin D. Number 5, I'm missing one. Oh, the big one, acid base. And number 6 will be red blood cells. So let's keep that off to the side. Sorry about the scribbles there. So that we can really see what we expect. We expect increased BUN and creatinine. We expect the itching and the pruritus. We expect peripheral neuropathy because we've got waste rolling around in our system. Blood pressure management, that should be on here as well. We expect increased blood pressure and increased fluid retention. And this is because the renin, angiotensin, aldosterone system is now being released from broken glomeruli and is increasing our blood pressure and increase our fluid retention and increasing our sodium retention. So let's add that. Let me clear that off of the scribbles here. And I am actually going to, let's see if it'll let me add this to the slide. Go back. Okay, I paused a bit to fix this slide up. Feel free to print. The next 2 slides I have cleaned up a little bit. Feel free to go back in and either rewrite your slides or fix up these slides. I will post the updated slides in modules. Anyway, so I think it makes a little bit more sense if we put the signs and symptoms or your expected cues under the jobs that the kidney is expected to do, so you can see what happens when the jobs don't get done. Waste product toxin excretion, we expect an increased BUN and creatinine. We expect those toxins to get out any way they can, so you will sweat them out, giving you itchy, dry skin. Those toxins do affect your nerves. You can get peripheral neuropathy, and part of, it's not really a toxin, but it's a waste product. Extra insulin that's circulating around usually gets removed by the kidney. So when we have a lot of insulin running around, the cells stop listening to insulin, so you get insulin resistance. Again, if you're not managing the blood pressure and fluid balance, the kidney, or it's secreting renin inappropriately, we get increased blood pressure, fluid retention, sodium retention, and a headache due to our brain getting overloaded with fluid, and it starts sending signals down to the kidney to get rid of some fluid. It's getting a little bit tight up here, and the kidney's not listening. Acid-base electrolyte balance, really at this point, when we're expecting it, we're not expecting things to go crazy. They just really, everything's kind of a little bit off. You could feel a little weak, you could feel a little tremory, you might get infections a little more often. Things aren't just quite right. Your acid base isn't bad yet, so those are kind of not really strong symptoms yet, but you do end up starting to have hypocalcemia and hyperphosphatemia, and you could have some borderline anemia, low red blood cells. As things get worse, as you progress through the stages, so really if we were doing expected cues, this would be kind of stages 3 or managed stages 4 and 5. This is what we expect to see. We're not trying to combat this stuff. We just expect to see it because the kidney's not working. Here's what become really things that we need to treat and symptoms that we need to manage. This is worsening cues. So if you're in stage 3 and you start having these cues, or if you're in stage 4 to 5, this will be time for you to call your doctor to get interventions. Continued nausea vomiting. Now, nausea vomiting is very weak of a symptom on its own, but when you have a lot of toxins in your system, you are going to be baseline nauseous all day long because of the number of toxins circulating around in your bloodstream. Some of these toxins can affect your brain, lethargy, coma, and the big one for toxins is this uremic syndrome. You can get pulmonary edema because the toxins are actually damaging your lungs and causing fluid to soak into your lungs. You can get these urea crystals depositing on the heart, causing chest pain. They're not having an MI, but they are having basically irritation of the myocardium, and that chest pain is usually relieved by sitting up and leaning forward. And then the picture up in the corner there is uremic frost. This is where the actual crystals are getting sweat out in your skin pores. The body's trying to get rid of these toxins however it can. The blood pressure management can get out of control. Maybe you're on blood pressure meds, but your fluid balance is out of control. That is causing, definitely, whenever we have fluid that's getting pushed out of our high pressure vessels, it will get pushed out into our extremities and into our lung space. Those are the weakest capillaries, and that's where fluid will get pushed out. And you end up with pulmonary edema and worsening pitting edema in your hands and feet. Now our acid base is starting to become apparent. This is where the patient is no longer maintaining their acid levels in stage 3 or earlier existing. They're maintaining, they're compensating, the lungs are compensating for the job that the kidneys aren't doing. They have a normal pH, but now we are getting acidotic. They can't retain bicarb to buffer all these acidic toxins that are in the bloodstream. You'll end up with high potassiums that could cause arrhythmias, and actually we end up wasting whatever pee you make. You're like, well, wait a minute, that doesn't make sense. We're supposed to be holding on to sodium. But remember, most of these patients by this stage are usually on some kind of ACE or ARB inhibitor. So the blood pressure isn't because of the renin any longer. The blood pressure is really because of the fluid that is holding on. And you're holding on to so much fluid that you are actually diluting out your sodium. So really renin, angiotensin, aldosterone system, by the stage 3, 4, 5, we've probably blocked that system off with an ACE inhibitor or an ARB. And so our signs and symptoms aren't really because of the renin, angiotensin, aldosterone system. It's because of the fluid management system and the kidney not able to pee. So we have so much fluid being held onto that it actually dilutes out that sodium level. Vitamin D, calcium absorption, and we just see worsening hypocalcemia, worsening hyperphosphatemia, and worsening anemia. So let's look at what we need to monitor. Since looking at our worsening signs and symptoms, we have pulmonary edema showing up in 2. The things that worry me most about these is the pulmonary edema, the cardiac chest pain, the hyperkalemia, and the acidosis. So we're looking at this stuff, and we want to monitor these things. If the patient is newly coming into stage 4, they will need to be talking with their doctor, and we'll talk about some of the teaching going on in here about possible treatment therapies. Obviously, we've moved into a higher stage now. You're having worsening symptoms. We're going to have to do something a little more invasive to control these symptoms. But in the meantime, we need to control any pulmonary edema that is showing up. So we're going to be listening for lung sounds. Any lethargy, confusion due to uremic toxins, any change in level of consciousness, we definitely want to get a control of. Blood pressure. Remember, the kidneys aren't peeing anymore. Maybe blood pressure meds they were taking aren't working any longer. We're now holding on to things. So what we're monitoring is for our worsening conditions and making sure that we get them under control as soon as possible. What we're going to do mostly is manage this fluid excess. So we're going to do least invasive to most invasive here. We're not doing most invasive yet. These are things we could do before going to dialysis, basically. So we're going to manage our fluid excess. First of all, the kidneys can't get rid of any of the fluid. They're starting to fail. So we can give them diuretics only if the kidneys can respond to diuretics. Piling diuretics on to a kidney that cannot produce urine any longer is basically a fool's errand, but they will try diuretics if the kidney is still responding. Here's where we get into fluid restriction. The kidney's not responding, or the kidney can't respond, we'll try fluid restriction, which is, we'll talk about in another slide. That's that star there, means there's another slide on it. Dialysis is most invasive, and if we can't get rid of our fluids via diuretics, we can't manage our fluid with fluid restriction, then dialysis is our next step. Manage the toxins. Again, dialysis is most invasive, so we can manage some of our toxins least invasively with oral meds. We've talked about K-oxalate already in acute renal failure, and in our electrolyte lecture. K-oxalate is for potassium. That's for high potassium. It will bind to potassium in the gut. And our other problem we have now is we have hypocalcemia and hyperphosphatemia. So we can bind phosphate. So we could throw a bunch of calcium at these people. They're already having a lot of issues with getting rid of extra fluids. They already have issues with not being able to produce vitamin D. So throwing calcium at them probably isn't going to be as helpful as doing a phosphate binder, because if we bind up phosphates in our intestine, then we will start rising our calcium level. Remember that inverse relationship. They can get calcium supplements as long as they are delivered with vitamin D, the active vitamin D, because we cannot convert it now because our kidney is broken. So they'll do phosphate binders, K-oxalate binders. When you give a phosphate binder, your calcium will slowly come up. But you will probably need to give a little bit of calcium and vitamin D as well. But they will definitely be on a phosphate binder to manage the hyperphosphatemia. They will be on K-oxalate to manage their hyperkalemia. And then if we cannot manage them with oral supplements or meds, then they will need dialysis. Hypertensive medications, again, may need some changing, may need to go up. If we're not blocking the angiotensin-renin-aldosterone system, now is a good time to do it. They might need to add on extra blood pressure meds. You may need to add in erythropoietin if your anemia is bad. And like I said, calcium, vitamin D supplements. If you have peripheral neuropathy, so any of the stars next to it means we have extra slides coming up on these things. There's a bunch of drug slides coming up for management of chronic kidney disease. Peripheral neuropathy is being managed by gabapentin, which is a med which eases nerve pain. Blood sugar control continues to be important. Remember, if we're headed into stage 4, we don't want to just push ourselves into stage 4, stage 5. Keep managing that blood sugar. Increasing, and the other reason to manage your blood sugar is if your blood is super sweet and thick with sugar, you're going to end up with more fluid in your bloodstream being pulled out of the tissues and into your bloodstream, and you're already fluid overloaded. It will worsen fluid overload. You will probably have increased cholesterol, and you'll be on statins for that. Lotions for the dry, itching skin, which is just going to happen. We're just sweating out, we're removing toxins from our skin pores. The renal diet now, 100% you got to follow it. Your kidneys are damaged, it can't manage its levels. You're going to have to manage the stuff that you take in so that the kidneys don't have to deal with as much waste. You have compromised immune system function just due to the fact that you're acidotic. Things aren't working in acidotic environment or nearly acidotic environment. Things start to break down. So here's a couple of slides on some of the details of our interventions here. Fluid restriction, again, is, I love that little puppy. Why? The more urine a patient produces, the more fluid they can drink. And like I said, these are ordered by the provider, but this is guidelines. And usually what providers will decide, they decide the amount of fluid restriction. They decide what the patient can drink. They may put them on a fluid restriction calculation. They may put them on an actual fluid restriction, 1,000 milliliters a day. If you're not making urine, really what you need to survive is about 1 liter of fluid a day. So if you're not making urine, you're anuric, which our goal, our definition of anuric is less than 50 cc's a day or 50 milliliters a day. Usually you're going to be limited to about a liter of fluid a day because you just can't handle any extra. Remember, when we tell you to drink adequate fluid or flush the kidneys 3 to 4 liters a day, that's with a kidney that can remove. That's to get your urine to be clear to pale yellow. If we're not making urine, then we're not going to overload the system with fluid to flush it. We've gone past the point of no return here in stages 3 through 5, and they are probably on some level of fluid restriction. If they are getting urine output, like I said, the physician's not going to monitor them on a daily basis if they're at home. Usually they measure their urine output over 24 hours, and they're allowed to add 500 to 1,000 milliliters a day plus their urine output. So if you put out, you may be less than adequate, because remember, in our 80 kilo person is supposed to put out 40 milliliters an hour, and anything less than that is less than adequate. So we're saying they're making urine output, but it's not adequate urine output. So maybe they put out a liter the day before. They had a good day, their kidneys were functioning somewhat, they put out a liter, well then they can have 2 liters of fluid the next day. It's usually 500 to 1,000 milliliters on top of whatever they peed out the day before. So they start being able to manage their fluid balance this way. Oh, I peed out 500 milliliters the day before, so I can have 1,500 milliliters today. It depends on what the physician tells them their calculation is. Watch your urine output, and then you can add some extra fluid on top of that. Patients with fluid restrictions, it's very hard to follow, especially in some place like Arizona. So here's some tips on how to get patients to be able to tolerate a fluid restriction. Drinking little bits more often, much more comfortable, stimulating saliva, things like that. The other thing to remember on a fluid restriction, and one of the things that is most I don't know if you went over this in block 1. Anything that is liquid at a room temperature is fluid. So we're not just talking about water. We're talking about Jell-O, ice, milk, juices, coffee. So now when you start thinking about all these things, soups, all these things are liquids. And so they all count into the fluid restriction. So imagine a patient that's drinking 1.5 liters of water a day, and then they're like, oh, well, I had 3 nutritional supplements and some ice cream. That adds to their fluid intake. And so sometimes that's something we're looking at when patients are coming with increased weight gain and increased fluid retention. What exactly is your understanding of your fluid restriction? Because fluids are anything that is liquid at a room temperature or melts at room temperature. Here's all of the pharmacology for chronic kidney disease. And when I'm counting this out, I mean, you probably know some of these already. If you don't know them, get comfortable with them. And if you have a patient that has in their chart that they are stage 3, 4, or 5 renal disease, they're probably on every single one of these meds. And the reason we're on it is to counteract a symptom or to replace something that the kidney already does. I'm not going to read each slide to you, but phosphate binders, make sure that you know any kind of binder or anything that is supposed to be binding with food should be taken with food. So phosphate binders should be taken with food so that it can bind the phosphates out of the food as it passes through the GI tract. Erythropoietin is a injection. It's IV or sub-Q only. And the important thing to remember off of erythropoietin, so let me just go back through and do a little my favorite underlining. For phosphate binders, take it after meals and snacks so that it is available for you. And they can decide, the physician can order a binder based on other electrolyte abnormalities there. You can have it added with calcium, you can have it added with magnesium. They don't do aluminum anymore. Those are gone. Aluminum is toxic and causes Alzheimer's. So these are the most common ones. Again, if you have a high calcium level, they would do calcium 3, but most patients aren't high calcium. Most of them are low calcium, so calcium-based phosphorus binders are good. Let's see. So, erythropoietin, one of the things I want you to remember on it is it's IV or subQ. There's no oral dose of erythropoietin, and we need to hold it if you don't need it, and let the doc know of the hemoglobin level. So you want to keep an eye and make sure that it is effective. It is supposed to stimulate red blood cells. So if we stimulate red blood cells, if our hemoglobin level is high, that means we have plenty of them and we don't need the erythropoietin dose. You want to make sure you have enough iron, because iron is used to hold hemoglobin on the red blood cells. So if you don't have enough iron, then you're making red blood cells that don't really work. So evaluating the iron levels as well, and that will make more sense after we do our hematology lecture. But again, with your erythropoietin, hold it if you don't need it, and keep your iron levels monitored. Gabapentin is the med for nerve pain, neuropathy. You may see diabetics with Neurontin, gabapentin. You may see diabetics with it. Two different reasons to have nerve pain with diabetics. It's the high blood sugar damages the nerves. With kidney disease, it's the toxins that damage the nerve. With high blood pressure and kidney disease, you have two things in there destroying the nerves. You may have much more nerve pain. So I just want you to know the important thing on this one is that it potentiates narcotics. So if you are on gabapentin and a narcotic, both of those will cause the drowsiness effect to be potentiated or added to. Statins, again, you've probably covered statins along there. Most of our patients are on statins, and statins have a lot of food medication interactions. So just double check all of those. If you see your patient on a statin, they're doing it to lower their cholesterol levels, which is fine, but monitor their food and medications with that. Again, just because you've moved into stage 3 or 4 does not mean that you need to stop doing your blood pressure management, your blood sugar management, your smoking habits. All of those things, if you do not get them under control, will continue to progress you down the pathway. It's not too late to stop your kidney damage in stage 3 maybe, rather than in stage 5, which is end-stage renal disease. Continue to be healthy, this is where you really do need to follow the renal diet though. Preventing further damage, renal diet, educate on the worsening cues, because when you do have those worsening cues, if you're in stage 3, it means you're probably moving to stage 4. If you're in stage 4, it probably means you're moving to a more invasive intervention like dialysis. When you're in end-stage renal disease, you're really into, you have to have dialysis to survive, and that's where the conversations start to happen on, do you want to stay on dialysis the rest of your life? Are you compatible? Are you available for a kidney transplant? Some patients don't want to do either and are, depending on their age and their other comorbidities, what they want to do with their life. So end-of-life decisions is an important conversation in end-stage renal disease. So we're going to talk about the invasive interventions here of hemodialysis and peritoneal dialysis. This is where we're actually going to go in and act as your kidney for you. There are two kinds. Hemodialysis is where you will be using a machine, and it will be pulling blood out of your body, filtering it, and putting blood back into your body. And it requires some kind of access into the bloodstream. Peritoneal dialysis is using your own peritoneal membrane in your abdomen as the filter. So you don't need to pull blood out of your body, filter it, and put it back. What we use is we use the peritoneal membrane as the filter. So there are pros and cons to each one. I have this video that is amazing. Please 100% watch it. I'm not going to play it on the recording, but I want you to stop right now and watch this video. Click on this video, go find your PowerPoint if you're taking notes on it. Find this video. It's also in the modules under supplemental material. Please, 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 please watch this video. 100%. I'm going to stop for just a second. This is where you pause this recording and go watch this video if you have not done so already. Okay, now that you've seen the video, I'm going to keep going. If you didn't watch it, go back and watch it, I swear. Please watch that video. It's amazing. Dr. Mike is amazing. Let's talk about peritoneal dialysis first. This is something that is better for the body than pulling our blood out, filtering it, and putting our blood back. This is better overall for the body, not without its set of risks, not easy to do. It will use our peritoneal membrane, which runs all along our intestines and all along, basically the whole entire abdomen. Every single organ is coated with this peritoneal membrane. And that acts as a great filter. And what it'll do is it's highly, highly vascularized with blood cells, a lot of capillaries because they're absorbing things from the intestines. And we will use this membrane as a filter. To get in there and to put things in and drain things out of this will require a peritoneal catheter that is surgically implanted into the abdomen, and there's a picture of it on the slide there. And what the patient gets is a prescription for a dialysate, which is a thick fluid filled with bicarb and other electrolytes, that basically when you put this fluid into your abdomen, you're bathing the fluid with a bicarbonate solution, and that pulls things out of the bloodstream and into your peritoneal cavity. So it changes, it osmoses through the peritoneal cavity. So you're putting basically a thick mixture with bicarbonate in it. What's it going to attract out of the bloodstream into that fluid? It's going to attract acids to buffer that bicarbonate. It's going to pull acids into that fluid. It's going to pull electrolytes into that fluid. It's going to pull waste into that fluid. It's specially formulated by the physician to pull things out of your bloodstream and into this fluid. The fluid, as it pulls acids and waste, will turn like a pale yellow, just like your urine. And then after the solution has bathed around your capillaries for a while, pulled what it needs to pull out of there, then we drain that fluid out. So that is what peritoneal dialysis does. It takes a solution that we specially formulate to attract wastes and acids out of our bloodstream, and then those things filter across the membrane, sit in the abdomen into the peritoneal fluid, and then we drain that peritoneal fluid out. It's a very effective replacement kidney. The patient is usually in charge of performing it. So you can see you need a very compliant patient. You need a patient that can follow directions, a patient that's not or has a good caregiver, not someone that has been non-compliant all along. They may not be the best candidate for peritoneal dialysis. It requires a great deal of care and discipline. The physician will order the dialysate fluid. They order the amount of time that the fluid's supposed to dwell in the abdominal cavity. They order the number of exchanges that you need to do. Now, just doing this once isn't going to be enough to pull out all the waste. The kidneys work 24 hours a day. We're going to do this solution, this exchange process a couple of times a day. Some patients are up to 10 exchanges a day. An exchange involves flowing the dialysate into the abdomen, the dwell time, which lets it sit in the abdomen and pull acids and electrolytes and waste out of the bloodstream and into the peritoneal cavity, and then the drain time, where the dialysate plus the waste all come out of the abdomen. So, don't worry too much about the different kinds. Some are manual, where you just hang the bags. You hang the solution bag, infuse it into the abdomen, and then wait your dwell time, and then open it up and let it drain out. They also have machines that control and weigh and do things for the patient. And a lot of they'll do 10 exchanges overnight, that while the patient sleeps, the machine will open and close valves on the bags and infuse dialysate, let it dwell, let it drain, and do the exchange multiple times overnight so that they basically get cleaned out overnight and then can go about their day the next day. Very convenient for patients who are still working, who don't have time to go to a dialysis center, who don't want to spend 3 days a week sitting in a dialysis chair. If the patient is, like I said, active, mobile, able to follow directions, peritoneal dialysis is a good choice for them. So it's so perfect. Why doesn't everyone do it? Mostly because of the side effects from it and the difficulty in maintaining your schedule. You have to be very rigid and disciplined to do this, to make sure that you get yourself taken care of properly. What we expect with peritoneal dialysis, that when we infuse probably a liter or two of fluid into our abdomen, you're going to feel full, bloated. There may be some pressure, mild cramping if it's cold fluid, but it is not painful. Don't worry about that. It is not painful. Your abdomen can hold quite a bit of fluid before it reaches pain level. So you can put 1 to 2 liters in that abdomen and it's perfectly fine. During the dwell time, the abdomen's going to feel full, bloated, slight shortness of breath if your abdomen is so full that it pushes up on your diaphragm. Again, should not cause pain. We expect that the fluids that drain out of there should be clear to pale yellow, just like our regular urine that we want. The amount of drainage coming out of the abdomen should be the same or more than the amount infused. Remember, we're pulling fluids into our abdomen. So if you put 2 liters of dialysate into your abdomen, when it pulls fluids and wastes out of your abdomen, you're probably going to get more than what you put in. That's expected and that's good. We don't want less coming out than we put in. That means the dialysate disappeared somewhere. We should be getting all the dialysate plus some extra fluid coming out of the abdomen. Skin around the catheter should be soft, non-tender, same color. Picture on the bottom is a picture of it going in. It does not look like a stoma. It's just a catheter inserted into the abdomen. Should be not red. It's okay to have a little bit of mucus discharge around the catheter. That's just white blood cells kind of coming to the surface and checking things out. But there should be no redness, swelling, tenderness, pain. No pain with peritoneal dialysis is normal. Most of these patients with peritoneal dialysis do lose extra protein. Remember, the capillaries around the intestines are pretty porous because they're absorbing things from the intestines. They are pretty porous and proteins can get through that filter. So these patients do lose more protein than normal dialysis patients do. So small amounts of protein are lost every time the dialysis is drained from the abdomen. So these patients can eat more protein than most renal diet patients because they're on peritoneal dialysis. What is not expected with the procedure, you can imagine, when we keep putting things in and taking things out of an abdomen space, our number one infection that we do not expect is infection. Our number one complication that we do not expect and is not okay is infection. How you notice the infection isn't necessarily a fever first off. The first thing that you're going to see is cloudy peritoneal drainage. It's just like cloudy urine. It means there are bacteria and casts and debris in there that we don't want. So if your peritoneal drainage is coming out looking cloudy or murky, there is probably an infection in there. Any abdominal pain during and after dwell time is something that needs to be checked out by the physician, could be sign of an infection. Of course, a firm, rigid abdomen, a sign of peritonitis or an infection of the peritoneal membrane, which is pretty common when we're moving things in and out of that catheter. If you're doing anything aseptically or not cleanly, you can get an infection right into your abdominal cavity. So increased temperature, skin red, painful, pus around the catheter. Remember, clear whitish, yellowish mucus is okay, but pus is not. But the first sign that you're going to see is cloudy drainage or murky drainage. The picture up there in the top corner shows a bag with infection in it and a bag without infection in it. One of the other problems that we can have, other than infection, again, the number one complication is infection. And before you're going to see a fever or anything, you're going to see that cloudy drainage or some abdominal pain that's usually people's first cue to go in and see the doctor, is it started to hurt. It's never hurt before. It's starting to hurt. That's the sign that the peritoneal membrane is getting irritated, possibly by an infection. So abdominal pain and cloudy drainage are your number one cues, and you should see a doctor at that point. Don't wait to get a fever or a firm, rigid abdomen. Go in and get treatment for your infection then. Hernias. This is where we're using a thin membrane to filter. Over time, you can get rips or tears in that membrane. You can get protrusion around that membrane. So damaged or weakened membranes causing hernias or leaks. The biggest sign of hernias or leaks are we put in a certain amount of dialysis and it doesn't all come out. If it doesn't all come out, then something is missing in there. That dialysate has leaked through to something else, or you have a hernia. They can facilitate drainage by changing position, gently pressing on abdomen to try to get all of that dialysate out of the abdomen. But if you are getting less out than you put in, there could be a membrane leak in there. For any complications, they need to notify the provider. For any infection or leak, the peritoneal dialysis needs to be stopped until it has healed. So you can imagine that if this is going to take 2 weeks to heal, then you might need some temporary dialysis during the time that you can't do peritoneal dialysis. So peritoneal dialysis patients, again, there's a lot of education involved in peritoneal dialysis. One, not even just how to do the procedure, but what to look for and when to notify the physician when peritoneal dialysis is having complications. So you can kind of read through there. If you are having less out than you put in, stand up, move around, massage the abdomen, try to get all of that dialysate out. You can have more protein than a normal hemodialysis patient because you lose protein every time you do an exchange. Constipation can cause the intestines to shift and dislodge the catheter or make the membranes more easy, prone to rupture. So avoiding constipation is real important when you have peritoneal dialysis. Remember, you don't have room for a swollen intestine when you're putting fluids in and out of your abdomen a couple of times a day. Peritoneal catheter care. These patients are very careful with this catheter. It's almost like a central line in its high risk of infection. And one patient, we were at clinical, and the student was doing a dressing change on the peritoneal catheter. And the patient said, be really careful with that. Put on a mask. And I want to watch your hands before then. She goes, this is my kidney. This catheter is my kidney. You wouldn't just go touching a kidney without washing your hands. So make sure that it is super, super clean as possible. When we're doing anything with this catheter in the hospital environment, it is a sterile procedure. It is their kidney. So we're going to treat it like it's a kidney sitting on the skin surface. And if they lose this due to infection, if they lose their access due to infection, you've cost them a whole bunch of hemodialysis while that infection clears up. So they know this. They take care of it. And if they can't take care of it, it might be not a good choice for them. But they can take showers with it. You can clean it with soap and cleanser, keep it clean, keep it dry, pat it dry, keep it covered, and keep it clean. And patients will get education on that, because if this gets infected, then peritoneal dialysis isn't going to work out. A couple of infections here and there, but if they're getting constant infections through their peritoneal catheter, the physician's going to switch them over to hemodialysis because it's just not worth the risk. We're going to talk a little bit about hemodialysis here. Hemodialysis is probably the one you're more common with. This is where we actually take we take the blood out of the body, filter it, and put it back in. It needs access to the blood as well. we can do a couple of different kinds of accesses, but instead of using our abdomen as a filter, we are using the dialysis machine as a filter. We still use dialysate, the thick fluid filled with bicarb, but it's infused into the filter, and it will exchange across a filter membrane on the machine. So access. To do this, we need access to blood vessels. We need kind of a big access because this machine is going to be sucking blood out of your body. So that requires a great deal of, I don't know if there's a better word for sucking pressure, but it creates a great deal of pressure. And so you need a large vein to pull this out of. So none of the veins in your arms are really large enough to withstand this pressure, so they create one. They create a monster vein in your arm. It's a monster artery vein, actually, and they're called fistulas and grafts. There's two kinds. A fistula is where a surgeon will go in and connect an artery and a vein to create turbulent flow, kind of like a big whirlpool right in there where the artery mixes with the vein, and it just creates turbulent flow and creates a really thick wall that's tolerant of multiple vena punctures. It takes 6 to 8 weeks for an AV fistula to mature or be able to use. So the time until use is 6 to 8 weeks. So, hey, you need dialysis tomorrow. You're not going to be able to put in an AV fistula. It's not going to work out. It takes 6 to 8 weeks, almost 2 months for these things to mature to use. So it's not something that can be done today and used tomorrow. An AV graft is when you don't have good veins to knock together. Many patients that finally end up on stage 5 probably don't have that great of veins to begin with. So if the surgeon does an analysis and says their veins are not good enough to create an AV fistula, they can do a synthetic graft, which is a bridge between an artery and a vein. And but these are not your own skin vessels, your own surfaces. It's a foreign object that you're putting in the body, and any foreign object that we put inside the body is at risk for being attacked by our immune system, which causes clotting. They're also more likely to be infected because they're not skin surfaces. They are not able to call the white blood cells over to clean things up like our skin surfaces and vessel surfaces are. So they're more likely to become infected, more likely to clot off. Because we're not waiting for 2 of our own vessels to heal, they mature a little quicker, but it's still a month. 2 weeks to a month. Again, not something that you could do if you want to do dialysis tomorrow. So AV fistula, AV graft are the best kinds of access. The fistula is the gold standard, the one that everybody wants. The graft is acceptable, but will probably clot off or become infected and need to be replaced sooner. And so those are the 2 kinds of preferred access for doing hemodialysis. These AV fistulas, even though they're the gold standard, they do end up clogging off, getting clotted off. They do end up stopping working, and they just basically leave it as is and anastomose another vein and vessel. So you sometimes see patients on hemodialysis that have multiple graft sites, multiple fistula sites. If a fistula has died off or doesn't work anymore, they just leave it and it becomes, an unusable fistula, but it stays there. They don't remove it or fix it or change it. So you sometimes see hemodialysis patients with big, knobbly, long fistula like arms and veins areas. You'd have to ask them which one is the actual active fistula. So those are our preferred accesses for long-term hemodialysis. What do you do if you need to do dialysis today or tomorrow? Maybe you've got an acute kidney injury patient that needs hemodialysis and doesn't need an AV fistula for long-term dialysis. They just need it for the next few weeks. Or you have a peritoneal dialysis patient that needs dialysis tomorrow because they have an infection, but they don't have time to wait 1 to 2 months for a fistula or a graft, and they're going to go back to peritoneal dialysis once everything heals. We use a temporary hemodialysis catheter, which you have probably seen. It is a central line. It's done in a large central vein so that the dialysis machine can withstand the pressure. Or so that the vein, doesn't collapse under the pressure of the dialysis machine. It's easy to place at the bedside or in interventional radiology, easily removed. But again, it's a central catheter. high risk of infection, you can use it immediately for dialysis. And these are our temporary access catheters. It's not a long-term plan. Most patients are not going to go home with a central line catheter that they're keeping for the next 5 years while they're on dialysis. We use this while treating acute kidney injury, doing emergency dialysis, just a one-time dialysis on maybe a drug overdose patient or something like that, or while you're waiting for your AV fistula graft to mature, or if your peritoneal membrane has gone down and you're waiting for it to heal. So these are temporary catheter access. It is a huge, large bore, double lumen. We don't touch it. It's our kidney. Again, only the dialysis nurses will mess around with it. We do not infuse meds through it. We don't push meds through it. We don't give meds. We don't give blood. We don't do anything with it. It's solely for dialysis. They do have a couple of these catheters that have a third infusion port coming out of that. So they have the 2 ports for dialysis and then a third one coming out of the middle that we can infuse on. That's the only way we can touch a hemodialysis catheter, is if it has an infusion port. So it is all central line care, and we do not flush it, touch it, pull anything from it, draw blood from it, anything from it. It's not ours to use. It is a kidney, and only the dialysis nurse can touch a kidney. We don't touch it. We don't touch peritoneal catheters either. Dialysis nurses will come and take care of those. If you have been specially trained to do peritoneal dialysis, you may do it, but otherwise they're not ours to touch. This is not testable. I just think it's interesting that basically you pull the blood out, put it through a blood pump, put it through the filter, and then it returns to the patient. Notice, though, that whenever we pull blood out of the body and put it back in the body and run it through pumps, it's much more likely to activate clotting factors. So the trauma of blood going through a pump activates platelets and causes clotting. So when you're doing dialysis, they usually infuse heparin into the bloodstream. They're getting a low dose of heparin every time they get dialysis, which can cause problems with bleeding afterwards. So we kind of talked about what we expect and what we don't expect with peritoneal dialysis. Let's talk about what we expect and what we don't expect with hemodialysis. If your patient has an AV graft or fistula, so one of those surgically created little arm fistulas, you will never, ever, you put a purple band on them or some band that says no venipunctures. The same as if you have a patient with lymphedema or something along that arm. We don't want anything ruining that kidney that they've put there. That's our kidney access. We don't want to ruin it. So no IVs, no blood draws, no blood pressures in any extremity with an AV graft. I don't care if the AV graft's in the forearm and you're doing it in the upper arm. Nothing in that arm. That arm has now become a kidney access, and we're not going to touch it. Monitoring of a patient with hemodialysis definitely waits. What we're looking for, I'm going to show you what we expect and what we don't expect. And the reason we're monitoring the blood pressure, heart rate, and temperature is for complications. Condition of the access, this is where we take a look at that arm, and we can assess. Even though I said we don't touch it, we're not going to do anything invasive in that arm. But you could certainly auscultate that access to make sure it's still good. The dialysis nurse will do that as well before they do access. But it's something that we can assess so that if there is a problem, we can call it out earlier rather than later before they call out the whole machine and get the dialysis nurse in the room if we think there's a problem with the access site. So we can look at the access site. We can auscultate it. I think, let's see if the sound works here for the Brewy. I might have I got to get you a new link for a Brewy. A Brewy sounds like a washing machine. Let's see if we can find one real quick. We don't want a heart murmur. It does sound like a heart murmur. You can do this, but... Oh, my speakers aren't working. Never mind. skip that. Find the sound of a bruit. Sounds kind of like a washing machine if you're listening to your washing machine in there. It sounds almost the same thing. You can palpate it. It actually vibrates under your fingers. You can auscultate it with your stethoscope. You'll hear the bruit. If you palpate it, it feels like a vibration underneath. It's not a pulse, it's a vibration. Check it and make sure that it doesn't look infected. Make sure it's not bleeding. And then we're also going to check if you have a AV graft or AV fistula in your right arm. You always want to take a look at your extremities below that, your fingers, look at the cap refill, circulation, make sure that the circulation is good. One thing I do want to point out is medications. If you have medications due to be administered prior to, I would say, the 1 to 2 hours prior to or during dialysis, those meds may get removed by dialysis. So any medication scheduled to be given when the patient's on hemodialysis should be held and given afterwards. And you can always call pharmacy or call the doctor to double check and say, if your patient's supposed to go down to dialysis at 10 o'clock and you've got a bunch of 10 o'clock meds, you might want to call and check with your doc and say, do you want these held till after dialysis? If you give them at 9:30 and they go to dialysis at 10, those meds just get pulled right out of the system because kidneys, will get rid of waste products. Those meds will get removed by the dialysis machine. So just double check with either the pharmacist or the doctor before, if you have meds in the hour or two before your patient is scheduled for dialysis. Usually they'll get their meds first thing in the morning and then schedule their dialysis in late morning or early afternoon. They adjust their med schedule to deal with dialysis. But that is something I want you to point out, that if you have meds scheduled during a patient dialysis time, don't just hurry up and give them right before they go downstairs for dialysis. They will be removed by the dialysis machine. So check that out with the pharmacist or your doctor first. What we expect afterwards is a little bit of disequilibrium on a patient that's had hemodialysis. Hemodialysis is not gentle. It's pretty rough. It will pull 3 to 4 liters off of a patient without even blinking. So you can imagine a patient that's fluid overloaded and has that degree of fluid shift afterwards may feel a little discombobulated for a little bit. We expect it. It's due to the rapid removal of volume, due to the rapid removal of acids. So you go from being acidotic to being alkalotic, or, within a period of an hour. You can get a little bit discombobulated. You get worse symptoms of disequilibrium if you were super high BUN or acidotic prior to dialysis. The worse you were prior to dialysis, the worse the disequilibrium feels like. It feels like hypotension. So these are the patients that drop their blood pressure right after dialysis. Well, of course, you dried the patient out. What happens during dialysis is it pulls 3 to 4 liters of fluid out of your bloodstream. And then slowly over the next 12, 24 hours, we will pull fluid out of the tissues and back into the bloodstream. But in the meantime, you're pretty hypotensive post-dialysis. Hypotension, tachycardic, nausea, dizziness, muscle cramps, just feeling sick, flu, discombobulated. So patients that go to hemodialysis aren't going in and doing a presentation at work right after hemodialysis. You do feel a little ill after dialysis because they've pulled so much fluid and so much waste, and until the body resets itself and gets things settled for a couple of hours, you're not going to feel that great. That is expected. We just don't want it to be going on too long. It's expected up to 24 hours after completion of dialysis, and like I said, it should re-equilibrate in a couple of hours, and I'll show you after what we don't expect. It is expected to ooze from the access site or need a pressure dressing after dialysis on that access site because heparin can prolong clotting at the site. So we expect those things. What we don't expect is that disequilibrium syndrome to cause such bad blood pressure less than 85, tachycardia. That means that we've pulled way too much fluid out of the bloodstream, that the patient is not even handling it very well. A little bit of hypotension, even down to 90 may be okay. But if this blood pressure drops below 85, if your heart rate goes above 110, your body is not handling it okay. That's something we would need to notify the physician of worsening disequilibrium. Sometimes pulling that extra fluid causes massive cerebral dehydration. So you could have altered level of consciousness. So your patient comes back from dialysis and isn't very responsive and tachycardic. That would be something that we would want to report and not just say, oh, they're having disequilibrium syndrome. That means you don't feel that great, but you still have a blood pressure and a decent heart rate. Super tachycardia, super low blood pressure, altered level of consciousness, not expected. We need to get a doctor involved in that. Symptoms lasting longer than 8 hours. Your body should re-equilibrate itself after, a couple of hours of having this feeling. If it's going on a long time, your body's not re-equilibrating and may want to notify the physician of that. Arterial steal syndrome happens during dialysis. And so the dialysis nurse will probably let you know to notify somebody, or they'll notify somebody. But when, because that AV graft or the AV fistula is created from an artery and a vein, that basically when the dialysis machine starts pulling blood, it actually sucks arterial blood from the hand. And that's called arterial steal syndrome. It's not expected. There's still supposed to be enough adequate arterial blood flow from another source that the hand does not lose perfusion during dialysis. So if the patient starts complaining of pain, numbness, and tingling in that hand below the access site that's worsening during dialysis, you will want to speak with the doctor about it. It can happen when you're not on dialysis as well. It would be certainly something if you have an AV graft site or a fistula site and the patient's complaining of numbness and tingling in that hand below the site. You should suspect arterial steal syndrome and that there's not adequate perfusion to that hand because of the fistula or the graft, and you'd want to notify the physician. Any excessive bleeding, they would need to check and double check the clotting levels. So if, the pressure dressing after dialysis, it saturates through and you're noticing bleeding from other parts of the body, that is not expected. It is expected to have bleeding enough that you might need a pressure dressing over the access site, not expected to be bleeding in other parts of your body or saturating through that graft dressing multiple times. And of course, we don't expect infection. But anytime we pull blood out of the body and put it back, if there's anything, any bacteria anywhere in that dialysis line, that will become a bloodstream infection. And then a little word about kidney transplant. This would be the best for a failing kidney, would be to get a brand new kidney that works. You only need one. Remember, we only need one kidney to survive, and we really only need a quarter of one kidney to survive. So getting a partial donor, a partial kidney, a full kidney from a donor would be the ideal. You would not need dialysis. Your new donated kidney would work just as well as your old one and would be the ideal, but unfortunately 93,000 patients are currently awaiting kidney transplants, and only 25% of those actually get a kidney. The earlier you get your kidney in your stage 3 through 5 process, the better off you're going to be. You can do living related. You can have a relative donate a kidney. They can have they have matches set up that, okay, if your husband wants to donate you a kidney but you're not the same blood type, your husband can donate to somebody and that person could then donate to you. They have chains that they set up that you can get donated kidneys from. You could do organ donation, and a patient that has died can donate a kidney. And then you could basically, you can just donate a kidney into the pool right now to give a kidney to somebody. But unfortunately, there are way more wants than donations out there. They do not remove your old kidneys when they put in a new kidney. So the picture up here where they have 3 kidneys, that is very typical afterwards. They're not going to go through the vascular risk of removing a kidney. They just leave your little kidneys in there to shrivel, and then they put in the new kidney with a new graft, with a new line. Again, what we expect post-kidney transplant, very similar to nephrectomy. you want to make sure that your urine output is good. The first sign of rejection, and we talk about that, that's the unexpected, will be a decreased urine output. So make sure that your urine stays adequate, maintain your urine catheter, strict intake output, and basically you're expecting your renal failure to resolve over time. The signs of electrolyte imbalances should improve, but when you get a new kidney in there that begins to function, it starts taking all of those electrolytes and blood and starts cleaning things up. So while that kidney starts cleaning things up, you have a period of imbalance for a little bit while that new kidney is working. Complications we don't expect, of course, bleeding, which would be similar to nephrectomy. Any bleeding, any Turner-Cullen sign, flank pain, bruising on the sides and the back. You would not expect the kidney to reject or be infected. Those are the two most common problems after procedure, is rejection and infection. Rejection is the first sign, is decreased urine output, and then you start having increased creatinine and BUN levels. Infection, the important thing to remember when you are getting a transplant of any kind, you are suppressing your response. You're going to try, the body is going to try and kill this thing that's not self. No matter, even if it's the right blood type, it's a foreign body. It will constantly be under attack. So I should probably put that in here, under here. They're going to get anti-rejection meds. We expect them to get anti-rejection medications to prevent rejection. They're going to be having strong immunosuppressants. Any patient with any kind of transplant is immunosuppressed to the point that they are at always a high risk of infection. But the immunosuppression is required to keep the organ functioning. So when the organ stops functioning or gets rejected, first thing you're going to see is a decreased urine output, but you may see a fever and an increased immune response from that as well. If you're seeing a fever in a transplant patient, there is something very, very wrong. Just like if you see a fever in a chemotherapy patient, something is very, very wrong. Transplant patients and chemotherapy patients are massively immune suppressed, and so they cannot create a fever. So even a low-grade fever in a transplant patient or a chemotherapy patient is an emergency, because if their weakened and suppressed immune system is mounting a fever, then there is something seriously, seriously wrong. So I would say probably one of the things that we're looking for post-transplant would be a decreased urine output, and even a low-grade fever. This is not the kind of patient that we're like, oh, low-grade fever, that's just inflammation. These patients are on anti-rejection meds, and they have a real hard time mounting a fever. So any infection will cause, you may have an infection without a fever, and that is a normal finding in a transplant or chemotherapy patient. So if it gets to the point of even a low-grade fever, you've got a pretty big infection going on. So in any transplant patient, whether it's liver, kidney, and usually chemotherapy along the same lines, if you have an infection, please let somebody, if you have a temperature, let somebody know. That's a late sign of an infection. So decreased urine output, any change in level of consciousness, any cloudy urine, any signs of infection, because fever is not going to be our first one that we see. Fever comes late in a transplant patient, and it comes late in a chemotherapy patient. So I think that is all I have for your renal lecture, or your chronic renal and your hemodialysis and your peritoneal dialysis. Let me know if you have questions in class.